Hello, everyone. Welcome to part 2 of chapter 5. We left off talking about generalized anxiety disorder, which is going to have one of the main characteristics of free-floating anxiety. So it's a general feeling. It's more vague of that uneasiness, except it's disproportionate to what the situations call for, and so it can span multiple domains. Whereas phobias, we're going to flip to the other end of the spectrum, and we look at persistent and unreasonable fears of particular objects, activities, or a situation. As you see on the right, there's pictures of some of the most common phobias people have, including snakes, spiders, this dog, and heights. I was going to put a picture of Pennywise, but I figured if someone had chlorophobia, that wouldn't be very nice. So instead, I put these other pictures. Hopefully, no one's too traumatized by those. Specific phobias are persistent fears of specific objects or situations. Those are all those different lists of phobias that you see. Agoraphobia, arachnophobia, chlorophobia, claustrophobia, all those types of things. And there's a whole section on agoraphobia on page 127. I'm not going to discuss it in depth on the PowerPoint just to save time since you all are going to read it. But let me know if you have any questions on it because I'll be glad to answer those. For phobias, now it's reasonable to have fears. You know, we all have fears or have had fears at one point in our life, and these are normal responses. Sometimes we had semi-traumatizing events as a result of an interaction with certain things or a fear of certain things. So that's totally normal. But a phobia, remember, we're talking about the difference between fear and anxiety and in an excessive sense. So phobias are going to be marked, persistent, and disproportionate fears of particular objects or situations for at least 6 months. Now, when someone has a phobia, let's say you have a phobia of spiders and you live in North Carolina, or cockroaches, I don't know, one of those things. We see those a lot, right? If someone has a really bad fear of those things, they may avoid, going outside at nighttime where the spiders tend to come out. They may avoid cleaning certain parts of their house. So you see how this is starting to impede their daily functioning. That's what we're looking at with phobias and what is considered diagnostic criteria. When someone's exposed to the object, it produces immediate fear. So maybe even talking about a spider can make them scared if they have arachnophobia. Avoidance of the feared situation, as I mentioned in my previous example, and it causes significant stress or impairment. So some people, even the thought of spiders causes them great distress. I know my sister-in-law gets that way, and so I'm kind of mean and I send her spider TikTok videos. Maybe I shouldn't do that. That's not nice. But that's an example of a phobia, right? She doesn't even want to see it on the screen. She's just, no, canceled. So with phobias, how do people get to be at this point where they have such an extreme reaction to different things? Well, we can thank a lot of behavioral aspects and cognitive behavioral aspects. Sometimes classical conditioning can play an extensive role into this. If you need a refresher on classical conditioning and behaviorism, please see the chapter 3 PowerPoint because I talked about it there, and I had review kind of refresher videos in our supplementary materials. Again, that was for chapter 3. But classical conditioning, we learn to associate these objects with different experiences. So let's say you get stung by a bee. That's painful, right? Well, you've learned to associate that pain with that bee. And so that may generalize to all bees, or maybe something more traumatic happened where you were bit by a dog. These kind of things can sow fear and phobias into people. Also modeling. So quick example, I had a little boy I used to nanny who had a phobia of bugs, any kind of bugs. He would, for lack of better words, freak out and run away when he thought he saw a bug or things that looked like bugs. It was a very extreme reaction. And so I found out one day that his mother was afraid of bugs. And when a bug would be near him, she would go, make a weird noise and try to shoo it off of him. Well, that mother's reaction is being modeled to her child in how to deal with this certain circumstance. So sometimes fears can be sown by our parents and what they've modeled for us. So if you do have a phobia or an extreme fear of anything, note that those are not the same. Check to see maybe if your parents have it. We can invest, you can do your own little case study on yourself there. And there's also this idea of behavioral evolutionary preparedness. So the idea that sometimes phobias are good for perpetuating our species. So we're more receptive to certain phobias like heights because it serves to protect us from different threats. So it's a really interesting behavioral evolutionary perspective, and that's also a question on your reading quiz this week. So if you're watching this lecture video, you're welcome. You got a free question for just doing what you're supposed to do. Good job. And so treatment for this is sometimes exposure treatment, so systematic desensitization, flooding, and modeling. So modeling in the way that we can model negative reactions, we can also do positive reactions. So maybe a therapist will help someone overcome their fear of spiders by maybe, I don't know, holding one. That's a little extreme. But modeling like, look, I'm doing this. It's okay. We're going to work through it. Systematic desensitization, in essence, is when you start small. You're systematically and incrementally moving to things that go from the least amount of anxiety to the most anxiety provoking. So let's say someone has an extreme fear of flying. They can't even talk about flying. So just makes their stomach sick and they can't even think about it. So let's start on what gives them the least amount of anxiety. If I wanted to utilize systematic desensitization on them, I would probably start somewhere having them meditate and imagine themselves on a flight. Okay, so we're trying to introduce them to a situation, but not traumatize them too quickly. And then we'll work up to more anxiety-provoking tasks. Maybe I'll drive them to an airport. Maybe I'll have them eventually get on a plane. Maybe I'll have them take a trip on a plane. That's systematic desensitization. We're slowly working through those anxieties to get the person to confront that phobia. Flooding is another way to expose people to their phobia, but it's doing it more rapidly. So just like a flood or rush of water comes in, you kind of rush them with the different stimuli. There's a clip on the next slide. That's the Maury show that talked about phobias. When I was a kid, stayed home sick from school, this is what was on. Not exactly child appropriate, but Maury show used to have people come on with all these kind of out there phobias, and they would supposedly cure these people after one trip on the Maury show. Well, odds are they used a lot of flooding and kind of sensory overload with that one stimuli, as you'll kind of see in the next video what they do. And sometimes this stuff can be these therapeutic methods can be in vivo or covert. So in vivo means like real life. We're going to actually experience them, whereas covert is more like imagining them, practicing that mindfulness. In vivo tends to have more support in terms of research and its efficacy. Excuse me, my mouse won't click. So here's the Maury show clip. You can click that. This woman is terrified of cockroaches. So you'll see how they kind of work through that. And it's interesting to note that the woman's daughter even gets scared of it. And she says because her mom reacted that way. And so that kind of demonstrates that modeling principle. Watch that video and let me know what you think. Now let's get to social anxiety disorder. So it's normal to care about what others think about us, right? We're human. We crave that interaction and that feedback from others. Social anxiety disorder is where it's kind of taken to the next level. Okay, this is pronounced, disproportionate, and repeated anxiety about social situations in which the individual could be exposed to possible scrutiny by others. So 6 months plus, those are the durations generally for this. These people tend to have really just dysfunctional beliefs about how they're perceived as a social person. And that's what we kind of see in these diagnostic criteria. They also have to have this fear of being negatively evaluated by or offensive to others. Again, a lot of this criteria, we could apply it to ourselves. Remember, we can. But um, there's also the duration and intensity we're looking for. So if you meet like one of these criteria for these disorders, you may think, oh my gosh, do I have that? Try to skip the self-diagnosis for now, because there are a lot of factors that come into that actually receiving a diagnosis such as social anxiety disorder. But if you should feel like you have something of the sort, please, contact me if you feel comfortable, and we can facilitate a meeting with one of the therapists on campus. Again, just my little blurb about not self-diagnosing, but sometimes the criteria seems so general. It's like, well, that could apply to anyone. Well, to have these specific diagnoses, you have to meet all of the criteria or the specific criteria put forward. So all of these bullet points you would have to have as diagnosed by a clinician. Anyway, tangents. You would also have exposure to a social situation almost always produces anxiety. So this could be even going out in public. This is where agoraphobia kind of can lend itself into that scenario. Sometimes if people are fear being judged or fear those social situations, they may kind of condition that or associate that with going out in public. So they may avoid going out in public or in the places where they would feel embarrassed, or maybe they'll only go in public with certain people, like a parent or a best friend or a sibling. Remember those main kind of categories is how does this distress the person and how does it disrupt their life. We're also going to have avoidance of feared situations. So sometimes people just avoid going out altogether. Or maybe if they were supposed to give a speech as a part of becoming a part of a certain club. I don't know. I'm just thinking of random examples. They may avoid trying to become a part of that club because they don't want to give a speech. And it can cause significant distress or impairment because socially, humans are social creatures. If we're not engaging socially, that's an impairment on our basic functions as a human. Relevant perspectives, again, cognitive behavioral therapy. We're looking at those thoughts and we're looking at the behaviors that follow. We have some dysfunctional beliefs, right? They're listed. I forgot the page number. Let me pull it up. Hold on. There was a nice list of the dysfunctional beliefs for you all to reference. On page 133. So it's talking about believing that the person is an unattractive social being, that they are socially unskilled, that they are always in danger of behaving incompetently in social situations, and believing that inept behaviors in social situations will inevitably lead to terrible consequences. So they're very extreme thoughts, not only in their abilities, but their expectations in their social interactions. So cognitive behavioral therapists are seeking to look at the cognitive component. What is this person thinking? What is going through their brain when they have these anxious episodes? And we're also going to look at their behaviors. So what behaviors do they engage in to try to protect themselves? So avoidance, do they avoid the situations altogether? And safety behaviors. Maybe they're really self-conscious about some mark on their face, a birthmark or something. Maybe they'll conceal it with makeup, and they don't want to leave the house without their makeup because they're so afraid of how people are going to judge them for their beauty mark. That's kind of what we're looking at here. And so treatment consists of exposure therapy. So sometimes we expose those people to different social situations that would make them uncomfortable. And it's really up to the clinician how they want to do that. Homework assignments also to help challenge beliefs. So when they're not in the session with the therapist, going home and really reflecting on those thought processes and trying to confront them. Social skills training is another possibility. This can be done solo or in groups. It's basically introducing people to social scenarios where they can role play the situation and kind of understand what's expected in that scenario, what others are thinking, and learn kind of those social norms. So they can role play, meaning they can kind of fake interactions. Kind of like if you've ever been nervous to give your order at a place. Some people rehearse it in their head. That's kind of like what you're doing with this role-playing treatment here. And so what I've included in this link is a wonderful video of a psychiatrist talking about social anxiety disorder and kind of dispelling some of the myths. It's a really good video. I highly recommend you check it out because she talks about the differences between normal social anxiety, a little bit of concern about what people think about us, versus a diagnosable disorder. Now we have panic disorder. Panic disorder is largely marked by unforeseen panic attacks that occur repeatedly. This is like the highlighting feature. So sometimes people misread their body's physiological cues. Maybe they'll have rapid heart rate as a result of running on the treadmill or walking outside, and they'll think, oh my goodness, my heart is racing too fast. There's something wrong with me. I'm going to die. Instead of thinking, oh, well, I just walked, around the block outside. That could be why my heart rate's up. It kind of deters and goes another way, and so sometimes that can be a feature of panic disorder. You also have one or more of the attacks precedes either of the following symptoms, at least a month of continual concern about having additional attacks. So sometimes you're like, oh, I've had this panic attack once. What if it happens again? What's going to happen again? Because quite literally, as someone who has had a panic attack, because largely about 1/3 of people have a panic attack in their life, you feel like you're going to die, and sometimes your thoughts are not rational surrounding that attack, and sometimes you are cognizant. But sometimes people get shaky, short of breath, sweaty. All these different things can happen. But you're concerned about having additional attacks, and you're also concerned. Another thing with the diagnosis is if you change your behavior associated with the attacks. So it says, for example, avoiding new experiences. If you refuse to go outside because you're scared of having an attack out in public or in a certain scenario, that is a sign of panic disorder. And so from a biological perspective, we look at that norepinephrine activity, so that a neurotransmitter looking through that panic circuit in our brain. Panic circuit tends to be hyperactive. It consists of, I think, 5 parts. Please read your text for further information on that, because I'm not going to list everything you have to read. And then the cognitive behavioral, again, I'm beating this perspective like a dead horse, right? Cognitive behavioral, looking at our thoughts and looking at the behaviors. A lot of times, like I said, people with panic disorder misinterpret their body's cues. And so they may have a heart palpitation, which causes them to think they're having a heart attack or dying or something of the sort. When really, it could just be they had a little bit of extra activity a few minutes prior. Treatment, you can use drug therapy or psychopharmacological interventions. Antidepressant drugs have been helped to help the norepinephrine activity return to normal, as well as kind of calming that panic circuit. In terms of CBT, there's what's called biological challenge tests, which I thought was interesting because it talks about invoking a panic attack in the person and kind of seeing how they react, and then helping them after you've done that assessment. So educating them about their panic attacks and ways to cope with it. I'm going to stop here and pick up on part 3.